Start the recording. All right, welcome everybody. I am very excited to introduce Dr. Alëna Bala-sa-nova, who is an assistant professor in the Department of Psychiatry at the University of Nebraska Medical Center. She is duly board certified in psychiatry and addiction medicine with specialized expertise and integrated treatment for substance use disorders co-occurring with other psychiatric conditions. After obtaining her undergraduate degree from the Johns Hopkins University, Dr. Bala-sa-nova went on to earn her MD at Harvard Medical School and completed her residency training at Boston University Medical Center. As the Director of Addiction Psychiatry Education for the Department of Psychiatry in the College of Medicine, Dr. Bala-sa-nova has developed novel educational programs for medical students, residents, and fellows, as well as allied health professionals. She is the founder and director of the Longitudinal Integrated Mental Health Substance Use Outpatient Clinic, which is an internationally recognized clinical experience for Creighton University psychiatry residents. Dr. Bala-sa-nova was the founding director of the Outpatient Addiction Psychiatry Clinic and also developed and now co-directs the Inpatient Addiction Psychiatry Consultation-Liaison service, both of which are at the Nebraska Medical Center. Dr. Bala-sa-nova's professional interests lie in the intersection of medical education and stigma reduction, and she has presented and published nationally and internationally on addiction psychiatry education and destigmatizing substance use disorders. In recognition of her work, she has been awarded the prestigious American Medical Association Foundation Award for Health Education in 2020 and the Nebraska Medical Association Young Physician of the Year Award in 2021. And without any further ado, I'd like to welcome Dr. Bala-sa-nova. Thanks for being here.
Thank you. Thank you so much. I'm really excited to be here. Thank you for that introduction. I love being a psychiatrist, and I extra love being an addiction psychiatrist. So I was really pumped to get to talk about this. And I wasn't sure if you had any specific questions for me to start, or you wanted me just to talk about my journey to becoming a psychiatrist. What is going to be the most helpful?
Yeah, I think it would be great if you'd like to start off by telling us a little bit about your journey into psychiatry and then how you have come down the path into addiction psychiatry.
Perfect. Well, so I always knew I wanted to be a psychiatrist, which is atypical. I think most people figure it out in med school, after you do your psychiatry clerkship and you end up really liking it. I went into med school. I was a psychology major, psychology and Spanish double major actually in undergrad. And I just loved the science and art of psychiatry. I truly felt like it was a field that married the two, the artistic side and the scientific side. And so I would, did pre-med and all that. And so then when I went to medical school, I had an open mind, but I knew in my heart that I really wanted to be a psychiatrist. So of course I became a psychiatrist. My second thing I had been thinking about was rheumatology, because I really liked rheumatology when I did it in medical school. But then I realized you'd have to do 3 years of internal medicine to get to rheumatology. And that was like off the table for me. That was not something that I wanted to do. So, the residency I did, Boston Medical Center, was a fantastic residency. And I encourage all of you to apply there. Boston Medical Center is a safety net hospital. So they really treat some of our most vulnerable patient populations. Many people were experiencing homelessness. Many people were non-English speaking. Some were undocumented. And a lot of them used injection drugs. That was something I didn't expect or anticipate. And I remember early on in residency, I really was eager to work with that patient population, the most vulnerable, because I really care about that population and I grew up in a similar fashion. So to me, it was really bringing it full circle. But what I didn't anticipate was all the substance use, because that's not something that I was familiar with or that I had ever experienced. And I actually was very turned off I really felt, I had all these stigmatizing attitudes that, I'm not here, I'm here to treat depression and anxiety, and when I think back to the things I would say, these are just drug addicts and, just not really deserving of this kind of care. And I kind of shudder and think about, I can't believe I had those attitudes, but I did. And I like to talk about that to show that stigma can change and attitudes can change and individuals can change, because right now I am the biggest proponent of stigma reduction and using clinically accurate language. That's one of my major research areas and areas of interest for education. But what ended up happening was, I was really invested in it and doing the best I could in residency, learning everything I could. And if that was the patient population that I had to treat, I was going to treat them whether I liked it or not. So eventually what ended up happening was, in working with these patients longitudinally, right? It's a 4-year residency for psychiatry. So by the time that I was a 3rd year, I'd been working with some of these patients for 2 years, starting with Outpatient Clinic in my 2nd year. And what I began to notice was that these patients were actually getting better. And it was pretty magical, actually, to be a part of that. Patients were putting their lives back together. They were becoming more, contributing members of society. They were getting jobs and participating in their children's homework and all these things that I just never thought possible. And when I initially had thought of working with these patients, and I basically had like an aha moment where I realized that substance use disorder is just like every other condition, every other medical condition, every other psychiatric condition. It is highly treatable, and that I really liked treating it. And I just didn't even realize that I did until I basically gave myself permission to like it. And since then, since kind of having that epiphany, I've just been the biggest cheerleader for this field, because I truly feel like it's not rocket science. Like, it's not that hard. It's just like anything else. And I think people shy away from it and people are scared of it, probably because of the same attitudes that I had, because I had a lot of really negative feelings about these patients and about this field until I just did it, until I experienced it and I realized I was completely wrong, and that I just needed to give it a shot and needed to give it a fair chance. And I think it also really helped that I had a lot of champion supervisors who were really excellent role models, because I remember in my first year, my intern year, our program director at the time was teaching us about substance use disorders and saying substance use disorders are psychiatric disorders. And I kind of like scoffed and was like, whatever, and that they are, brain diseases. And I remember saying, well, if somebody has a genetic predisposition and they know that, they may develop a substance use disorder, then isn't it their choice to use that substance and then, put themselves in a position where they could develop that substance use disorder? And I remember the program director telling me, sure, maybe, but what about when you have appendicitis and you need to have surgery and you need opioids for your surgery for your pain? You didn't choose to take them. You had to take them because of the pain and the nature of the surgery. So what then? Like, how is that in any way your fault when your body physiology takes over? And that stuck with me. I remembered that. I kind of didn't pay it much mind, but later when I finally understood, I realized that she was right the entire time. And over the course of my residency, I had a lot of role models like that and champions and just individuals who normalized substance use as a psychiatric condition that all psychiatrists should treat, general, not general, that it's something that we just encounter day to day. All of my outpatient experiences were in general clinic settings. They were all co-occurring disorders because that's the patient population. It wasn't like we were specifically, seeing patients in a substance use clinic. That was just the patient population that we had, which I thought was really cool, in retrospect. So by the time I realized that I really liked this, but at the end of 3rd year of residency, I kind of had this thought of, do I need to do a fellowship? Because we had a fellowship at Boston Medical Center, has an excellent addiction psychiatry fellowship. It's a 1-year fellowship. And our associate program director at the time of the residency was the program director of the fellowship. And so, I realized that a lot of the fellowship, not all, but a lot of it was really similar rotations, and some actually of the same rotations that I had already done in residency, because our residency had such a robust education and training experience in addictions. And I realized that perhaps I could make a bigger impact if I just went straight to practice, especially if I did it somewhere where there is no addiction services. And I moved back to Nebraska after I graduated, which is where I'm from. And here at the University of Nebraska Medical Center, actually just today we had a news release come out, it's very timely, on an opioid withdrawal order set that I developed for our health system that's launching, which is a really big deal to treat opioid withdrawal in the hospital. But, that just shows how far we've come in 5 years. So since I've arrived, I've really been like the physician psychiatrist champion for addiction care. And I've been able to, like when you were introducing me, all those things that I've started, all of those little by little were parts of training that I had, that I wanted to pay forward, that I wanted to bring here. So LIMSOC, the Longitudinal Integrated Mental Health Outpatient Clinic, is a 1.5 day experience longitudinally for 3rd-year psychiatry residents. And it's in clinic and you're supervised directly by me. And it's 100%, emulating what I had, because I had that for 2 years. And we had 4 half days, actually, I think total in that time. So just reducing it to the amount possible and just trying to replicate these experiences, because I think it was that longitudinal experience that allowed me to see patients get better. I think so often we have our addiction rotations in emergency departments or, detox facilities or inpatient facilities where patients are at their worst. I mean, they're very sick, they're coming in at a very low point. And if that's all we see, I think we get jaded and we think that's all there is and that patients never get better. But that's just not true. We know that patients get better, and I know that patients get better because I've seen it. And I think giving us and learners the opportunity to see that by working with patients longitudinally is really important. So that's why that was one of the very first things that I developed was LIMSOC. And then little by little, we have built upon that. So now I co-direct the Addiction Psychiatry Consultation-Liaison service, which is one of few in the country that serves as a core clerkship site for the 3rd-year psychiatry clerkship in medical school. So it is very rare for somebody's clerkship site to be an addiction psychiatry co-occurring disorder site, but that's what we have. And we also have a 4th-year medical student elective in which you also do your buprenorphine training. Your 8-hour waiver course is a part of that elective. So all of the 4th-year medical students do complete that training by the time they graduate as part of their elective. And it's really awesome to see medical students experience addictions care through a harm reduction paradigm, through motivational interviewing. I mean, we had just last week, I was teaching the students about opioid use disorders and using buprenorphine and using methadone. And one of the students asked me, well, how long do you have to be on methadone? And I said, well, how long do you have to be on lisinopril, like for your high blood pressure? And it was like, there was just like this moment where they were like, oh, because nobody ever realizes that these are chronic conditions and they're just like high blood pressure. They're just like diabetes. They're honestly no different. They can be treated and managed for the rest of your life. You just have to find a physician who is willing, comfortable, competent, and compassionate enough to treat you the way that you should be treated. And so it's those moments that I really live for, those educational moments. To see stigma being broken down, right in front of my very eyes is pretty amazing. And so I really do enjoy that academic part of what I do. I'm about 50% clinical, and then the rest of the time I spent with academic projects, with research, and with some administrative duties. So that's what I do these days. And that was my journey to becoming an addiction psychiatrist. I should mention, so I didn't do the fellowship. And you might wonder how am I board certified? Well, there's two pathways. So there's addiction psychiatry, which has been the long-standing one. It's accredited by the American Board of Psychiatry and Neurology, ABPN, which is the same board that accredits general psychiatry. And addiction medicine is another option. So that also has its own board, the American Board of Preventative Medicine, and it's relatively new. It's only been around since 2016 as part of the American Board of Medical Specialties, ABMS. And until 2025, so you guys will be outside the window, but until 2025, individuals can do what is called the practice pathway for addiction medicine, which means that you have to have 1,920 hours in the preceding 2 years documented in working with patients with substance use disorders in substance use related fields. And if you submit that, you're eligible to sit for the board certification examination, which is what I did. And so then I passed that exam and thereby became board certified. Now I have to pass an exam every 10 years, as with all board certifications. Starting in 2025, the practice pathway will no longer exist, and you will have to do an addiction medicine fellowship to get board certified in addiction medicine, much like you have to do an addiction psychiatry fellowship to get board certified in addiction psychiatry, because that doesn't have a practice pathway option since it's been around for so long. The only reason addiction medicine has a practice pathway option is because it's new. And so to give people the opportunity to get board certified. So as someone whose primary training and board certification is in psychiatry, you can do addiction medicine or addiction psychiatry and still be an addiction psychiatrist, right? That is my identity. That is who I am, even though I'm board certified in addiction medicine. But I am on top of being a psychiatrist first and foremost.
Great, thank you so much for that. And I guess what does a typical day look like for you now as an addiction psychiatrist?
Yeah, well, so my days are variable. So my Mondays, so Monday mornings are for research. So I'm on an R01, which is a federally funded grant looking at anxiety and alcohol. So anxiety disorders and early abstinence from alcohol, and whether anxiety can trigger relapse in early abstinence. And we're doing brain imaging and looking at a particular area of the brain that's responsible for anxiety. And so that's been really interesting to be a part of that research study as the content expert, the clinical co-investigator. So providing the clinical expertise for diagnosing the anxiety disorders, diagnosing the alcohol use disorders in the participants of the study, and then having a colleague who is 100% research that is more of a clinical investigator. So in the afternoon, then on Mondays, I do LIMSOC. So that is when the Longitudinal Integrated Mental Health Substance Use Outpatient Clinic occurs. And so it's 4 hours from 1 to 5. I have one resident who I directly supervise. So there's cameras in the room. And so I directly supervise all of his patient encounters, and I'm able to give him feedback, discuss all of his cases afterwards. Same thing with Zoom. I'm able to sit in on his Zoom sessions as well. So then that's the duration. Then we have supervision at the end of the day. So then we talk about all of his cases. Tuesdays, I'm on service, which means I'm on the addiction psych consult service. And all day long, I am on the consult service. So I'm the attending of record. So I lead a team of, sometimes we have a fellow, we'll have a resident, we'll have usually 3 medical students, which is a combination of 3rd year and 4th year. And then we often have a PA student as well, because we are very interdisciplinary, and I do a lot of education for the PAs in the PA school. So that is my Tuesday. My Wednesday, as you can see, there's a lot of variability, and I really like it that way. I think the really cool thing about addiction psychiatry is that it is very flexible, and it lends itself to a lot of different things. I'm one of those people that can't do the same thing every day all day because I would be bored. So I really like the variety in what I get to do in the different clinical settings. On Wednesday mornings, I typically will see my own patients, my own outpatients. I have a small panel of outpatients that I see that I've been seeing for over 5 years. And then in the afternoons, I'm on the consult service again. The Wednesday afternoons, I'm on the consult service. On Thursdays, that entire day is education and administration for me. So that is my one day where I don't see any patients. And I work on, writing projects. I have several outside contracts with entities to provide education about opioid safety, other harm reduction initiatives in our community, like with naloxone and things of that nature. Fridays, I'm back on the consult service again. So Fridays and Tuesdays are basically the same in terms of leading the team on the consult service. So there's a lot of variety in what I do, and I really like it that way.
Nice. It's always fun to hear about a specialty that allows you to kind of customize your schedule in that same way, especially if you do like the variety of practice.
Exactly.
Yeah. So one of the questions that were submitted was, what would you say is like the most exciting part of your career, and what is something that's a little bit more daunting?
Yeah, that's a really great question. I think I touched on this earlier. I think what is most exciting is actually the clinician educator aspect of what I do. So again, working with medical students and residents, with learners of all types, and honestly giving them what I had, giving them the experience that I had that was so eye-opening for me. It's so important to me to now be that same role model for others that I had when I was in residency, because if it weren't for those role models and those clinical experiences, I would never be in this field. I would have never even considered it. I was grossed out by it, and the attitudes that I had were completely atrocious and wrong. And I just want an opportunity to pay that forward and to help other medical students and other learners make their own minds up, and be exposed to the good parts and be exposed to patients getting better. And again, just sort of seeing that stigma being broken down right in front of me is something truly remarkable and really what fills my cup with regard to my career. In terms of what's daunting, so as I'm sure you know, many physicians are now employed physicians. Maybe you don't know this, but compared to like 50 years ago, over 50%, actually well over 50% of physicians are not independent practices. That's how it used to be back in the day. You'd have, a physician private practice or a group practice, or in psychiatrists, there's oftentimes solo practice. Well, these days, more and more healthcare systems are employing physicians. So just by nature of how medicine has moved into more of an administrative realm, so to speak. So I think as an employed physician, what is somewhat daunting are some of the regulatory burdens. So, something called RVUs, which are relative value units. So you have to get a certain number of those units per year to support your salary. And those units come from the number of patients that you see and what service you provide to those patients. So things like that, like number crunching, things that are not direct patient care related, that are less of the human side of medicine, but a reality in the business of medicine, which is very important to know about to be able to live in that system. So I think that's a little bit more of the daunting aspect, is some of the regulatory kind of administrative burdens that take me away from direct patient care, but are a necessary beast if you are an employed physician working in a healthcare system.
Great. Thank you for that honesty. I think, especially as a medical student, I don't know if the rest of the audience can relate, but I feel like that aspect is like missing from our curriculum. And I almost wish it was there, just because I feel like going into residency and leaving residency, I would want to know exactly what that looks like.
It's true. Yeah, I think actually it's interesting because as a resident, I was shielded from it in many ways. And I think residents are shielded from it in many ways because we want to optimize your learning experience so that you get the knowledge and the skill set clinically. But then what ends up happening is when you become an attending, it's a very abrupt change and you're expected to know all these things and you never really were exposed to them or got to learn about them. So I do know the AMA has some seminars and webinars for medical students, the American Medical Association, that can help with that. They do have some content available. So I would take a look at their website if you guys want to educate yourselves a little bit more, because they do a lot in that arena.
Awesome, thank you. I do want to take this time to just open it up to the audience. If you guys have any questions, feel free to unmute yourselves and ask.
I'm sort of curious. So you mentioning that sort of the administrative burden of psychiatry is difficult for you seems to be a very common trend among physicians and among psychiatrists. And it may be that, you know, you're right and there's no really escaping that. But I'm curious, sort of both speaking as an addiction psychiatrist and just as a psychiatrist in general, what do you think would be the path if that would lead to like the least amount of administrative burden for a psychiatrist?
That's a really interesting question. Thank you for posing it. You know, I think there's administrative burden regardless of which route you pursue. So I know several, private practice psychiatrists who I know some that work in solo practice and then some that work in a group practice. They too have administrative burdens. They're just different. So, you know, I talked about the RVUs. In private practice, the administrative burdens are, you know, you're responsible for billing insurance. You're responsible for making sure you see a sufficient volume of patients to keep your practice open, to keep the lights on in your office, right? And so that's a whole nother headache that fortunately I don't have to have because of the nature of being an employed physician. So it's almost like a trade-off. And I feel like there's going to be administrative burden either way. It's just what kind of administrative burden it is. And I think you just have to ask yourself when you're approaching that time, you know, what am I more inclined for? And do I want to be responsible for all these nitty-gritty things, or do I just want somebody else to take care of that for me? Because that's what happens with me. I don't have to worry about insurance or any of those sorts of things, which is a luxury of being an employed physician. But I do have to worry about things like RVUs and, you know, a 3-day documentation rate. If I were, for example, a private practice physician, I could write my notes whenever I wanted to write my notes because this is my private practice. There's nobody, you know, watching me. But in my healthcare system, the notes have to be completed within 3 days, which is actually a pretty good thing, but I'm just bringing it up as an example of the differences, right? So a healthcare system can impose those sorts of rules, which again, to be honest, I think that's a good rule. Like you want to be timely with your documentation. But that's just another way that the two differ, the private practice and the employed physicians. I do believe, though, that psychiatrists remain the highest private practice specialty of all specialties, if I recall, in terms of solo practices. At least that was the case when I was in residency. So, 6-7 years ago, that was the case. That might have changed now. And certainly I don't know how COVID has impacted. I don't think we have numbers yet to really fully understand how COVID has impacted private practice versus employed physicians. What I do know is that COVID has had a really interesting impact on addiction psychiatry and the practice of addiction psychiatry, because we very quickly pivoted to telehealth for our patients. And there's two camps. There's a camp that is really pro telehealth and says that it's been life-saving for patients. And there's another camp that's, with some data coming out, that is identifying that for some patients, telehealth is really not optimal. Maybe patients who are a little bit sicker, who need more accountability, who need to show up to the clinic. And so without the ability to demonstrate that accountability, those patients aren't doing as well with telehealth. So we're only now beginning to see some of those emerging trends, which is interesting. I think somebody wrote something in the chat. So to those
I can read it.
Oh, go
go
ahead.
for it. No, go ahead.
Oh, so to those who cannot pursue the Practice Pathway 2025 cutoff, what is your opinion in pursuing the Addiction Psychiatry Medicine Fellowship? Because it seems like you gained a significant amount of knowledge during your residency training. So what would be the possible benefits of doing the fellowship outside of the certification, since a general psychiatrist can typically fill an addiction role? Excellent question. So I think my experience was unique. Boston Medical Center and the Boston University Residency is well known for being heavy in addictions training. It's just very well known for that. Unfortunately, the same cannot be said for other psychiatry residencies. And in fact, the great majority of psychiatry residencies have very limited addictions training outside of the 1 month required FTE. So all of the ACGME psychiatry residencies are required to have a 1 month equivalent of addiction psychiatry. That's actually the most lopsided requirement insofar as the percentage of patients that you see with substance use disorders and the percentage of time devoted to learning about substance use disorders. It's only 2% of your entire residency, right? And like 50% of the patients you see are going to have substance use disorders. I'm actually on various task forces nationally, working with the American Association of Directors of Psychiatry Residency training right now on the Addictions Committee to develop recommendations to the RRC, which is what through ACGME works on developing the residencies, on changing some of those addiction requirements to enhance them, to make sure we really want it to be at least 2 months minimum. We want buprenorphine training to be a part of it. We want more exposure to longitudinal addictions care. Unfortunately, because of the nature of addiction and the stigma, and the fact that historically that there's been treatment silos and addiction's been treated separate and different than the rest of medicine, many times residents don't have opportunities to rotate through somewhere that's evidence-based. You know, many times the rotations are in like faith-based, abstinence-only places that are not the standard of care. But that's all that's available in that area, in that community. And so that's all the residents have access to. So I would actually very much recommend doing a fellowship, absolutely doing a fellowship. And I'm biased being a psychiatrist because I would recommend doing an addiction psychiatry fellowship, because that really is going to go into the weeds on how to treat substance use disorders in context of severe and persistent mental illness, in context of very sick individuals and how those two are intertwined. Because I will say like 90% of the patients I see have another psychiatric disorder as well. It is so rare just to have a substance use disorder and not have depression, anxiety, PTSD, or personality disorder. I will say personality disorder is one of the highest comorbidities actually. So I would highly, highly recommend doing a fellowship. If you are someone that, you know, maybe you feel very comfortable with after residency with all of the psychiatric elements and you want to foray more into the physical aspects of addiction, that would be more of the addiction medicine route. You would do more infectious diseases work, hepatitis, HIV, sequela from injection drug use, things of that nature. So you would get liver transplant, things like that. I will say there's a lot of overlap because we do that too on my consult service. So we do all those things, but you would just get more training in them, I think, through an addiction medicine fellowship than addiction psychiatry. Although again, there's a lot of overlap. So yeah, so I guess sort of to answer your question, a general psychiatrist can't typically fill an addictions role, but can sometimes and maybe rarely, but I was fortunate to be one of the ones that could because of the nature of the kind of residency that I had. So when you guys are applying for residencies and you're interested in this field, be sure to look at what the electives are, what the actual rotations are that you have in a certain area. It would be really important to know if it's in an ED, if it's in a detox unit, if it's you have a longitudinal clinic, right? All of those training experiences are very important, and you can learn about what's available in that residency when you're applying to it.
Hi, I had a question as well, but first I did want to say I actually knew when I was 13 that I wanted to be a psychiatrist, and I was a psychology major in undergrad, so there's a few of us actually.
Yes, there
Some of
are.
us,
I like it. Solidarity.
yeah, Yeah, and I haven't changed my mind, and I'm in my third year, so we'll see.
Yeah.
Yeah, but kind of almost following on what Lauren said, I am wondering how many psychiatrists are, like non-addiction psychiatrists, are comfortable with treating addiction, because I have known at least a few psychiatrists who will say, "Oh, we don't do that. We don't do that. We treat mood disorders, we treat psychosis, so they just don't treat addiction at all."
Mhm. Yeah, no, you're right. I mean, I think a good portion of general psychiatrists don't treat addiction. And I think stigma certainly is a part of it. But to be perfectly honest, I think a major reason for that is that they never received sufficient training and education. And so they don't feel comfortable in their own knowledge base and skill set to provide that kind of care, which I mean, I certainly, it's like me trying to do surgery. Like I'm obviously not qualified in any possible way. And many times general psychiatrists feel completely unqualified because they just did not get that education and training that they needed to be able to confidently care for patients with substance use disorders, at least the bare minimum, screening, maybe giving them naltrexone or some, low level medication. And if it gets complex, referring out to a colleague, who maybe manages more. But I mean, I've seen some psychiatrists employ a don't ask, don't tell policy where basically they don't ask about substance use. And then that way they don't hear anything they may not know what to do with. Because and then if the patient says they are struggling with something, then the psychiatrist has to do something about it. But if they don't know what to do about it, that puts them in a tricky spot. So I do think it's crucially important that general psychiatry residencies amp up their game in substance use disorder education and training. I'm sure you saw recently the numbers came out. There were over 100,000 overdose deaths last year, which is a new record in the United States. It's a horrible record, but it is a record. So with COVID, the rate of drug overdose death has accelerated, and that's a different kinds of drugs too, and a mixture of drugs. Psychostimulant overdose deaths have increased by 180%. Of course, we have our synthetics, opioids, fentanyl, carfentanil, all of those. And the mixture of those with benzodiazepines is a big one too. So I do think that there needs to be enhanced training in general psychiatry residencies. But if you happen to love the residency that you're going to, and you don't have a very good experience in addictions care, or a very robust experience, I should say, then absolutely pursue a fellowship, because that's where you will get that. You'll get a whole year of it, where you will know the ins and outs of everything. And there's still some things that because I didn't do a fellowship, I do feel very comfortable and confident with many things. One thing that I know addiction psychiatry fellowship these days are incorporating is pain and pain management. And that's something that I never got because I didn't do a fellowship. So pain management is something I don't do because it's something that I don't have any skill set or knowledge base in treating. So fortunately, I have a very collaborative relationship with our pain physicians at our institution. And so we work very closely together, which is great. I don't think that's always available or the case at different places across the country. But I do know that many fellowship trained addiction psychiatrists do some level of pain care because they received that education and training in their fellowship, especially nowadays with increased LCME and ACGME requirements for education around pain.
Shelby, did you have a question?
Who?
I think Shelby had a question. I'm not sure.
Yeah, there's another question, I think, in the chat as well. But I was interested in, it sounds like you have a lot of responsibilities with your multiple positions. Do you incorporate psychotherapy into your practice, or do you collaborate with other mental health providers for that aspect?
Yeah, I'm so glad you asked that because I love psychotherapy. So psychotherapy is my second love after addictions. And oddly enough, my residency again was very heavy in addictions and very heavy in psychodynamic psychotherapy. And again, also very well known for that. for psychodynamic psychotherapy. So I received very good training in psychotherapy. And I feel very strongly about the importance of teaching psychotherapy and incorporating psychotherapy. So I absolutely incorporate it into my outpatient practice. I incorporate it into LIMSOC by teaching the resident about psychotherapy, particularly harm reduction psychotherapy. And I was so pumped about our new psychiatry residency. So UNMC, my institution, has a new psychiatry residency that's only like 2 years old. We have our second class right now. And I developed and teach the Introduction to Psychotherapy course for the general psychiatry residency. So something totally different than addictions, but the introduction to psychodynamics and introduction to psychotherapy. It's a 12-session course for the second year psychiatry residents who are just beginning their psychotherapy education, which is mostly with psychologists and social workers as their teachers. And I felt it was really important that they also have psychiatrist role models, because unfortunately it is a dying art, I think, in psychiatry, partly because of administration, partly because of what gets paid and reimbursed better. But I think it's essential as part of our identity as psychiatrists to do psychotherapy. It's that art part of what we do, and that's what drew me to psychiatry in the first place, the art and the science. And so if we just did the science without the art, I just wouldn't be happy, because it would only be half of what I wanted to do. So yeah, I absolutely employ psychotherapy. That's not the case for all addiction psychiatrists. I do think all addiction psychiatrists have a rudimentary understanding of motivational interviewing and use motivational interviewing on a regular basis, which is a kind of psychotherapy in its own right. But I do more formal psychotherapy. In fact, I've had patients that I saw just for psychotherapy and not for any kind of medications. I don't presently have any of those patients, but I did up to like last year.
Awesome. Thank you.
Mm-hmm. Yeah, and the chat question says, oh, no camera at the hospital. Yes, I know that. Do you feel comfortable with the medical risks of detoxification, sympathetic response, et cetera? And if so, how did you gain this comfort level? Yes, well, the first thing I'll say is I've used the term detox unit because I don't know what else to call them, but detoxification is not a term that we're really using anymore. We're saying withdrawal management. So I suppose I could say withdrawal management units, but that sounds really clunky, doesn't it? So typically when somebody is admitted, we try not to say admitted for detox, but admitted for withdrawal management, because that is what they're admitted for. If you think about it, what does detox mean? Like, we're taking out your toxins? Like, it doesn't really make any sense. And again, it just goes back to this idea of somebody being dirty and uncleansed when they were using substances, these very sort of archaic notions. So again, one of those stigma reducing mechanisms is to use more clinically accurate terminology. So with regard to withdrawal management, so I gained a lot of comfort with that in residency on my consultation liaison rotations. So consultation liaison is its own, as I'm sure you've learned, special subspecialty, and mostly occurring in the inpatient setting, although some in outpatient as well. And in the inpatient setting, that is where you see consults for medically and surgically hospitalized patients. And so I saw many patients who were experiencing withdrawal, and we had to assist with the withdrawal management. So I feel very comfortable with it from residency. And then also now as an attending, it's a regular part of what I do as part of the addiction psych consult service. In fact, recently we developed a new protocol for my hospital using phenobarbital as an agent to help with withdrawal instead of benzodiazepines, which is what is used presently. So we now have another protocol that uses phenobarbital in the ICU for more severe cases. And it was really neat to work with critical care medicine to develop that protocol. So I think you will, in general, on your consultation liaison rotations, you should experience some level of withdrawal management, understanding the sympathetic response and those sorts of things.
Great, thank you. I wanted to ask if there were students who wanted to get involved and get more exposure to addiction psychiatry, what would you recommend that they could do as medical students?
Yeah, that's a great question. So the American Academy of Addiction Psychiatry AAAP for short. That is our National Professional Society. I'm actually on the board of directors. And we welcome medical students. We have many medical student awards actually, and like mini scholarships. Actually, I nominated a medical student this past year for an award and he received it. And so part of that is you get free registration to our national conference, which is next week, actually. I'll be giving a workshop on incorporating medical students into existing clinical services in addiction psychiatry. So very apropos. But that is one really excellent way to get involved, is to network with other members. You know, I had a medical student once just literally reach out to me as part of AAAP asking if I wanted to be one of the kind of senior people on a workshop that she was doing. And I was like, yeah, I'm like, why not? Like, this is great. And so then I got to meet her and collaborate with her. And so you can just really like, you know, call someone up or email them. And once you have that network, there's also a mentorship network where you're able to get a mentor, request a mentor that has been in the field for however long you wish. You can specify. I don't know if it's always granted, but you can always specify. So that can be really helpful as well. But that would be my biggest recommendation for a national society that you can get involved with and attend the meetings. It's a little more challenging, of course, on Zoom, but there are certain perks. So some of the medical students that won the awards are going to have a very special reception on Zoom with some of the leaders of the field, where they'll get to chat with them. And it's a closed Zoom meeting just for them. So, you know, kind of trying to emulate like a little networking event. So I would definitely just look up like AAAP on the website, or Google it and you can find the website.
Great. Yeah, I would highly recommend AAAP as well. I was able to submit some of my work last year when the conference went virtual. So I highly recommend it to everybody. Yeah, any other questions, you guys? I want to give you guys the time we have about like 15 minutes left, a little under 15.
If nobody else has anything, I have another question. So kind of within third year, rotating through all the different specialties, there's definitely obviously encountering a lot of the stigma around patients with substance use disorder or patients that are receiving MAT. Do you have any advice or like a general way that you approach people that are kind of talking in a negative manner about those patients?
Yeah, that's a really great question. And I know it's really challenging as a third year medical student because there's such a hierarchy. And of course, I don't want to put you in a position where you're, you know, at risk of your grade being lower or something, you know, because of you basically pointing out that somebody's being stigmatizing. And I think depending on sort of the level of seniority of the individual, like maybe if it's a resident that you're working with, many times medical students work closely with the residents. Maybe when you're one-on-one with that person, you could mention something like, hey, I noticed back there when we were talking about that patient, like you just sounded kind of negative when you were talking about them. And I was just wondering, you know, why that was, because I'm learning and I'm just trying to understand, you know, how sort of medicine works. And so can you help me understand that in sort of a very non-confrontational way, but maybe pointing it out, because I would bet that most people that are stigmatizing don't even recognize it. Like to them, it's just like going about their day. Like they just don't even pay attention to it. And so I almost think that pointing it out to somebody in a very non-confrontational, friendly manner might be eye-opening, because then they might think like, oh, I was like, how was I negative? Like they didn't, because they just don't recognize it. And then you could say, oh, well, maybe when you call them a substance abuser instead of a patient with a substance use disorder, or, you know, very simple things like that. I wish I could say you could do the same for your attendings, but I wouldn't advise that because of unfortunately how the medical school hierarchy works, you know, like that's just not something that you're in a position to do given the power differential. Sometimes even I don't do that with super senior people to me and I'm an attending, you know, usually other attendings at my level, I will. But sometimes if it's, you know, like the CEO of the hospital or something, I'm not going to call them out. But I have been known to follow up by email after meetings with people and say, hey, just in case you were interested in some of these resources, and I'll send them resources on language and using clinically accurate language. And so I'm not really calling them out, but I'm just giving them information on if they would like to change the way they talk moving forward. This way they can learn how to do that. I like to fall back on the Surgeon General's guidance. So the Surgeon General has a great lexicon that you're always able to, it's like a one-page sheet that talks about the correct clinical terms. And I think that's a really great place to start with stigma, is just using the correct terminology. There's been a lot of research that shows that when we use stigmatizing terms, we actually provide worse care due to unconscious bias. So if we're just changing our language, that's going to go a long way to improving the stigma and improving the way that we care for these patients. So that's one way, is to kind of focus on the language. Everybody knows me as like the language police, because whenever they rotate through, that's like what the students all tell each other in advance, like, oh, okay, Dr. B is really into language, make sure you use the right language. But by the time they're done on our site, it's second nature. Like, they don't have to think about using language because it's second nature, because they've been using it for 3 weeks or for a month. And then it's funny because I'll hear them say, wow, now I'm really noticing like how everyone says abuse and everybody writes abuse and all this stuff. And so it's kind of fun then to see them cringe when they hear it, when they were using it, a few weeks ago. It just reminds me of myself, I think, and the way that I was in residency.
Thank you.
Oh, and I see you put the link for AAAP. Thank you for doing that.
No problem. A question we'd like to ask all of our guest speakers is, what's one way that you combat, I guess, like physician burnout, especially in a field that kind of needs a lot of attention?
Yeah, it's hard, right? Physician burnout is real, and now medical students are experiencing burnout. We've come to a place that's not a great one for that, right? And for wellness and all these wellness initiatives like ice cream day and stuff, like that doesn't cut it, we know that doesn't cut it. Yoga, you can't yoga your way out of this, I like to say. I think one, you have to set boundaries. So as a psychiatrist, I think it's really important to have boundaries. And I think that also not only with your patients, but I think with yourself and with your work. So I was on call all weekend, and it was kind of, I was getting woken up a lot during the night. I had to go in during the days. And so I took today off because I didn't want to work for, 7 days straight, actually like 10 days straight. And I saw, I was off today doing errands and doing all my life things that I didn't do this weekend because I was working. And I was getting I saw my phone like blowing up with emails. But I made the decision that I wasn't going to deal with that today because I'm not working today. And so although I see there's a long list of emails that are waiting to be read, like I set the boundary that like I'm not going to go down that rabbit hole. I'm not going to feel compelled to respond to all these things that can wait until tomorrow because I have an auto away message that says I'm not in today. So, that's just one way, because I certainly know colleagues that don't do that and they will respond. And so then they will, try to do everything, try to do life and try to do work at the same time. And that's a recipe for burnout in my book. You have to set time aside. I feel strongly about leaving work at work and then coming home and having my home life. I have twins who are going to be 4 in January. So my hands are full. Like the minute I leave work, my mom hat I put my mom hat on and I don't have time for anything else. So it's almost a natural boundary where I focus on that. And then once I drop them off at daycare, then I can put on my psychiatrist hat again and, go to work and focus more on that. And so for me, having boundaries has been helpful. And I think I've learned how to develop those boundaries over time. I don't think I was as good at it when I first started practice, when I just was fresh out of residency, because in residency, you don't have a lot of boundaries and everything blurs together. You're just trying to survive. That's just how it works. And I think certainly before kids, I would bring home work all the time, but now it's just not an option. And it's a nice natural boundary that I've set for myself.
That's awesome. Thank you so much for sharing that. And I want to thank you for spending your evening with us. I know it's your day off, but I think we've all taken away so much about addiction and its role in psychiatry and how we can contribute. I want to thank everybody here for being a part of the series. I know some of you guys have been trekking along through each one, so PsychSIGN appreciates you. And yeah, thank you all. If there
I
are
do
no
have one
more-
thing. Somebody
Yeah.
sent me a direct message just asking about if they can still attend the AAAP conference, which is December 9th through 12th. So like I said, it's just coming up. Go to the website. I mean, in my head, I don't see why not, but go to the website because I know that you can register. If it's in person, you can register on site. So in theory, you should be able to go and register and attend. I don't know if that's the case online, but if you go to the website and go to meetings, then there might be a way, or email them if you can't find a way on the website. That might be another option.
Yeah, I just want to confirm, you can actually still register. So I tried to do it right now and it says registration is open and you can register for whoever's interested.
Okay, perfect. Wonderful. Yeah, so do that. If you want to, go ahead and do it. And attend my workshop on Saturday.
Yay, perfect. Thank you so much. Thank you all for being here. Have a wonderful evening.
Thanks, everyone. Go into
Thanks,
Addiction Psych. It's the best. Bye.
Bye.